Welcome everybody. Today we will be talking about the different types of diabetes drugs. As you see here, we have quite a list to discuss today. We're going to start with insulin, the big insulin, and as we work down, as soon as we get down kind of to the bottom of the list, they're not as important. However, these kind of top 5 are going to be your big diabetes drugs. These are going to be your mainstay. So there's type 1 diabetes and there's type 2 diabetes mellitus. So the difference between these two, type 1, you cannot make your own insulin. The mainstay for treatment then is going to be insulin. However, for type 2 diabetes, you have decreased insulin tolerance pretty much. The insulin that you normally make isn't as effective. So how do you treat it? Well, we're going to use insulins, we're going to use all these different types of drugs. So type 2 is a little more complex for treatment. Also, a good lifestyle modification is the number 1 stay. So if you're ever asked a question, what is the first treatment that you should do for type 2 diabetes? It's insulin. It's not insulin. Not insulin. My apologies. It's diet and lifestyle modifications. Exercise. Change your food. Change the way you eat. For type 1, the mainstay for treatment is going to be insulin. So type 2, number 1, diet, exercise. That's a big point to remember. If anybody asks what the number 1 treatment is, it's going to be lifestyle modifications work first. If these lifestyle modifications fail, then you move into drugs. So keep that in mind. But otherwise, we'll talk about the main talking points, the key buzzwords, the stuff that will get you test points. We will go over stuff that will get you the main buzzwords, the main concepts. My goal is to get you test points. I don't care what level you're testing at, whether you're an undergraduate, whether you're in a graduate program, whether you're taking a board exam. This is the lecture that will get you test points regarding diabetes drugs and explain some of the differences. So let's go ahead and start with the first one, insulin. Very important for type 1 diabetes. Now there's a whole bunch of different types. There's going to be rapid acting. There's going to be short acting, intermediate, and then there's long. Okay, I'm going to get a little smaller pen here because we have a lot to talk about for insulin. We're just going to cover the main different categories. So rapid. When you think rapid insulin, I want you to think 3 main prototypical insulin-like drugs. Well, first, we're going to start out with Lispro. That is going to be a main one. We've also got Aspart. And we've also got Glulisine. So when I say rapid acting insulin, we're talking, stuff that lasts, that starts immediately almost and lasts for anywhere from 3 to 5 hours. So about 4 hours of action. So it's going to be rapid acting, and this is the stuff that you may see in insulin pumps, because in insulin pumps you're monitoring your insulin or your glucose levels every so often, and you're going to modify it by using a rapid acting insulin in those pumps. We also got short acting insulin. Well, what's the difference? Well, rapid was about 4 hours of action. Short is going to last anywhere from 4 to 12 hours of action. So it's going to be anywhere from a shorter duration, anywhere to half a day or so. So what is the short acting insulin? Well, that's just going to be your regular. That's just going to be your normal insulin that you synthesize naturally by the body. However, you can do synthetic regular insulin, especially in the case of type 1 diabetes where you don't create your own. That's just going to be regular insulin. Alright, we've also got intermediate. This is going to be NPH. That's going to be your prototypical intermediate insulin. And then long acting, we've got Argine and Detamir. Okay. Want to know one of the tips that I use to remember the long-acting insulins? So I'm thinking of a pirate. Pirates, glar. Pirates like to say glar, They're a little rough. And then they also like to have long-lasting debts. So GLAR, me det, is very long-lasting. So detamir and glargine. That'll help you remember long-acting insulins. Think pirates. So intermediates. Intermediates are going to last, so shorts are 4 to 12. These are going to last anywhere from 10 to 20 hours. Not quite the full day. While long-actings, on the other hand, will last anywhere from 14 to 24 hours. So this will last almost the full day. So you'll only have a one-time injection theoretically. One of the main concepts that I'm not going to touch is you can use different dosings and combine these. So you might do a low dose of long-acting insulin at the beginning of the day, and then multiple dosings of a short or a rapid-acting insulin. It just depends on the clinician's feature. It depends on the patient. But just realize that you don't just give one type of insulin for the most part, unless if you're in a pump or in certain situations. Otherwise, you give maybe a long-acting and a short-acting between meals, like right after a meal. So I mean, that's just a variation, but I'm not going to go into that. So we're going to make a new slide here. Insulin continued. My goal is to try and keep everything to one slide. For insulin, since it's so important, I am going to try and take 2 slides, but everything else I'll try and limit to at least 1 slide, or to at most 1 slide. So let's talk about how insulin works. We just injected normal, regular, short-acting insulin into the body. How is this going to exert its effect? Well, you have insulin receptors. Insulin receptors are going to be transmembrane. What does that mean? They're going to have an extracellular and an intracellular component. They're going to span the phospholipid bilayer membrane. So they're going to be exposed to the surface of the cell and the inside of the cell. So on the cytosolic side, once insulin has bound to the extracellular binding site for this insulin receptor, the intracellular or the cytoplasmic side, either one interchangeably, has a tyrosine kinase activity. The tyrosine kinase activity is going to add a phosphate onto stuff. So we're going to take an enzyme, we're going to phosphorylate it. So this tyrosine kinase is going to take an enzyme, it's going to phosphorylate it, and so we're just attaching phosphates onto stuff. Just adding phosphate groups, and those phosphates will come from ATP. So ATP will go to ADP, and in the process, this phosphate, the triphosphate to a diphosphate, that phosphate that we lose gets stuck onto an enzyme. So we have a phosphorylated enzyme. It's going to activate stuff. So when you add a phosphate onto that enzyme, you're going to activate it. So you're going to exert some downstream effects. And when I say downstream effects, you're going to phosphorylate a whole bunch of enzymes, turn those enzymes into active enzymes. You're going to have downstream effects because these enzymes will be active. So what effects will we see? Well, you may see increased glucose uptake into cells. Now let's recall what's the function of insulin. It's to take a hyperglycemic state, so you have a high blood glucose level. It'll drive that glucose into the cell. That is the point of insulin, is you're going to take a high blood glucose concentration in the bloodstream. So GLU, those stands for glucose. You're going to drive, when you give insulin, you're going to drive the blood glucose into cells. So you're going to decrease your bloodstream glucose levels. So one of the downstream effects will be increased glucose uptake. Also, you're going to have more glucose into the cells, so what that'll do is it'll drive glycogen formation. Now your liver and your skeletal muscle cells will synthesize glycogen. Glycogen is just going to be your stored form of glucose. So if you have increased glucose in the cell, the cells will say, hey, we have excess glucose, let's just store it. And that's in the form of glycogen. Also remember that when you increase glucose uptake into cells, you take potassium with it. So as you take glucose into cells, potassium will go with it into the cell. So you possibly could have hypokalemia. Hypokalemia is decreased potassium in the bloodstream. So that could be a side effect of a massive dose of insulin. So you have to be careful with that. So that's kind of the mechanism for insulin. Now let's move on to a different category. Biguanides. So the biguanides are going to be, they're going to be a category of drug, but the prototypical drug that you will see in the real world, type 2 diabetics. This is a major player. I would remember this one. The biguanides are going to be metformin. That's going to be your prototypical drug of choice. So the mechanism of action is actually a little unclear. What we do know is that we're going to use this as a first-line treatment for diabetes. It's going to be an oral medicine. It's going to be one of your first-line treatments, and it's going to be specifically for type 2 diabetic patients. Now, what does happen when you give biguanides, even though we don't know the exact mechanism of action, we do know that you're going to decrease hepatic glucose formation. Now, remember, I'm going to go back a slide here. Remember I just said that when you take glucose up with insulin into the cell, you're going to synthesize glycogen. Now, glycogen is your storage of glucose. Now, metformin is going to decrease hepatic glucose formation. We're going to decrease gluconeogenesis, but we're also going to decrease glycogen breakdown, which will spit out kind of glucose into the bloodstream, increasing our blood glucose. All of these, all diabetic drugs aim to decrease glucose in blood. That's just kind of, I should have said that a little earlier, that's just kind of a general rule of thumb. Our goal is to decrease our hyperglycemic state, our high glucose state in the bloodstream. So diabetic patients may have too much glucose in their bloodstream. All of these drugs, via different mechanisms, will aim to decrease the glucose in the bloodstream. And metformin works by decreasing hepatic, so your liver's ability to form glucose. Also, it's going to increase peripheral glucose uptake. So it's going to increase your peripheral glucose uptake. You have a whole bunch of glucose in your bloodstream. Metformin will increase the uptake of that glucose in your peripheral cells, so your muscles, for example. And that glucose will go into the cell, kind of like the same mechanism of insulin. Okay, so board questions. If there's one question that I've gotten multiple times, it would be this. Which of the following drugs can lead to a lactic acidosis? Lactic acidosis. Well, it's going to be your metformin. They're going to give you a whole list of different diabetic drugs. They'll have metformin as one of them. This is your money question right here. I've been asked this multiple times in multiple different board question banks. Now, lactic acidosis, do not forget this. It also causes other complaints such as like a bad taste in mouth. It also can cause GI disturbances. But the number one adverse effect of metformin is going to be your lactic acidosis. This is important This is something that you need to commit to memory. So even though we don't know the exact mechanism of action for metformin, we do know that it does exert some effects. We know that it's effective. That's why it's going to be our first line treatment. It's going to be one of our #1 drugs that we use in type 2 diabetes after they eat correctly and after they exercise. If their diabetes can be controlled with diet and exercise, excellent. We don't need drugs. But if it cannot, we need to think about implementing metformin in their regimen. And one of the side effects that we need to monitor with metformin is going to be a lactic acidosis. So that is metformin. That is an important high yield topic. Next, we've got another category, the sulfonylureas. Now, there's quite a few different drugs. So the biguanides is just pretty much the prototypical metformin. For the insulins, there are just different modifications of the insulin. For the sulfonylureas, we'll have quite a few, and I'm just going to list out them right now. If you want to save 10 seconds of your life, you can go ahead and skip forward in this video. Otherwise, I'm just going to write these out. Okay, so here are some of your prototypical sulfonylurea drugs. Now, just realize that there are going to be some first-gen drugs, there's going to be some second-generation drugs. Not that important to distinguish between the two of them. Just realize that there's different categories of the sulfonylureas, and you'll be good. Also, we're going to talk about the general mechanism of action for these sulfonylureas. So, we've got cell here, and it's going to be a beta cell. So the beta cells are going to be your insulin releasing cells in your pancreas. So hopefully you know the difference between alpha and beta and delta and all those different pancreatic cell types. Your beta cells are going to be your endocrine cells that release insulin into your bloodstream. So we've got a cell here, and you know that we have some GLUT transporters, the GLUT transporters. Now there's a whole bunch of different types, not important for right now, so I'm just going to keep it basic. We've got a GLUT transporter, and it's going to be on the surface of the cell. What that's going to do is it's going to take glucose and bring that glucose into the cell. So these pancreatic cells, even though they're releasing glucose, what they'll be doing is they'll be taking up small amounts of glucose. They'll kind of be sampling. These GLUT transporters specific to the pancreas will kind of be sampling how much glucose is in the bloodstream. And if we have a high amount of glucose into the bloodstream, we'll be taking in a lot of glucose during our sample, kind of our test of the environment. So if we have a high amount of glucose will go into the cell during our test. So high glucose. Now, what typically is going to happen is typically this high amount of glucose is going to cause a high amount of insulin release. Now, what's going to happen in diabetics is you're going to have this high amount of glucose, except the pancreatic cells won't respond as well. What we can do is, I'll go through the basic physiology here. You've got a potassium channel. See if I can keep this. So we've got a potassium channel here. What typically is going to happen is normally you have a high amount of potassium inside the cell. Remember, sodium's on the outside, potassium's on the inside. It's maintained by the sodium-potassium ATPase pump. So you're going to have a pump over here, it's going to use ATP. Potassium normally is going to diffuse out of the cell. So when that happens, we've got another channel over here. I'm just going to make a complete picture and then I'll walk through kind of what's going to happen. We've got a calcium channel. Calcium typically comes into the cell and it'll depolarize the cell. And then lastly, we've got insulin, because remember, these pancreatic beta cells produce insulin, so we're going to have a whole bunch of synthesized insulin ready to go, and then it'll get released once we have some calcium. So what will normally happen is we'll have some glucose come in, we'll have a high amount of glucose come in, that'll depolarize the cell. Depolarization is going to cause calcium to come in. Calcium coming in is going to cause insulin release. That is the normal physiology of things. Calcium coming into the cell is our ultimate goal because that'll produce insulin release. Insulin goes into bloodstream. That's what happens. But however, we've got a class of drugs called the sulfonylureas. The sulfonylureas. What they do is they're going to inhibit this potassium channel. So in a normal potassium channel, potassium is going to diffuse out of the cell to try and keep the charges normal. However, I'm just going to shorthand it sulfonylureas, SUs. Sulfonylureas are going to inhibit this channel. So this channel cannot happen. Therefore, our potassium is going to stay inside the cell. We're going to have an increased concentration of potassium in the cell. Now, a positive charge, a high positive charge in the cell is going to depolarize that beta cell. We're going to decrease, or we're going to increase the polarization. We're going to cause depolarization within the cell. That's what I was looking for. We're going to cause depolarization. When we depolarize this cell, calcium is going to rush in because you're going to have a concentration gradient, but depolarizes causes calcium to rush in. That calcium, I've already said, causes insulin release. Sulfonylureas increase insulin release. That's a main point to remember. That's your take home, is what they're going to do is they're going to inhibit this potassium channel. So they're going to increase insulin release by inhibiting potassium channel. That inhibiting the potassium channel is going to increase the depolarization. Depolarization will cause the calcium influx, causing insulin release. Big point to remember. Now you've got a couple adverse effects. Let's kind of take a tiny little area out here. What can happen? Well, you can have hypoglycemia. Hypoglycemia. Typically in a diabetic, you're hyperglycemia. You have too much glucose. However, if you don't give the correct dosing for the sulfonylureas, you may have a side effect of hypoglycemia. You have too much insulin being released. So you inhibit this potassium channel really well. You get a depolarization, you get an increased insulin release. You release too much insulin, you're going to have decreased glucose in blood, and that will manifest into your hypoglycemia. Also, disulfiram. So disulfiram is going to be a drug given to alcoholics. It's going to block the breakdown of acetaldehyde, which is going to be like a toxic metabolite in your liver. And when you do that, you're going to get nausea, you're going to get throwing up. And that's what they give to alcoholics to try and kind of mentally convert them to the associating drinking alcohol to throwing up. So every time they drink alcohol, you're going to get a whole bunch of toxic metabolite built up. It'll cause them to become sick. So it'll cause a disulfiram-like effect. So disulfiram is a drug that's given to alcoholics. So this will be a disulfiram-like effect. Sulfonylureas cause a disulfiram-like effect. And then lastly, you may have GI disturbances as well. GI disturbances. So that's the sulfonylurea in a nutshell. That's the high yield information that you should know. Next we're going to talk about the glitazones. Now, can also be known as the thiazolinodiones. So I'm going to call them the glitazones from here on out. Couple different categories that are pretty much interchangeable for our sake. Now, there is a way that I can remember these two drugs. So we've got prototypical drug number 1, pioglitazone. Then we've also got rosiglitazone. So notice their endings. Both end in zone. Now let me tell you a little story here. I got to give credits. This is how I remember my glitazones and their mechanism of action. I got to give credit to who kind of came up with this mnemonic. In school, me and my buddy Eric Mortons always came up with mnemonics to remember things. Kind of like that pirate one, for example. For our glitazones, he came up with this one. So we're both terrible at golf. I mean, we love to play, but we're terrible. I mean, it's really just a drunk fest when it happens. But however, when we're betting money or whatever on our golf game, you need to get in the zone. So when you play golf, you need to get in the zone. When you play golf, get in the zone. Why do I say golf necessarily? Well, it's because in golf, we're not very good, so par is a really good score for us. When we're in the zone, we always shoot for par in golf. So the PPAR gamma to be specific, however, for our sake, when you're in the zone playing golf, you always shoot for par. So the glitazones are gonna work by binding the PPAR gamma receptor. Now, that's going to be their mechanism of action, MOA, mechanism of action. They're going to bind PPAR gamma receptor. What this is going to do is we're going to increase the GLUT4. Remember, the different subtypes really don't matter. They're going to increase the GLUT transporters, which is going to increase glucose into the cell. Perfect. So what does PPAR stand for? It doesn't really matter. It stands for peroxisome proliferator activated receptor type gamma. Not important at all. What is important is just realize that you're going to increase your PPAR gamma. Glitazones will go and bind to this PPAR gamma. What that'll do is it'll increase the transcription and the translation. Transcription is it'll transcribe your DNA into mRNA, then it'll translate that mRNA into GLUT4 transporters. They'll stick those GLUT4 transporters up into the cell membrane. What that'll do is you'll increase the glucose into the cell. That is your target goal. Remember, we have too much glucose in a normal diabetic, type 2 diabetic, too much glucose in the bloodstream, so our goal is to put it into the cells as reservoirs. Adverse effects. Let's finish that one up. Not too many. When you think glitazones, think heart problems. You know, in all those golf commercials, they always talk about heart problems. Just remember that. In a lot of golf commercials that you see on TV, depending on where you are, I guess, you have a lot of heart problems. All those old men want to get back out to the golf course. They have heart problems that are kind of preventing them from getting in the zone to get par in their golf game. Also, hepatotoxicity is a pretty big one. You'll see hepatotoxicity, so damage to the liver. So that's the glitazones. And we're going to finish up with the last super important one. I mean, they're all kind of important, but really these are the top 5. We've covered 4 already, and there's going to be 7 that we're going to touch upon. This is going to be the last one that's going to be the most important. So we've got the Alpha-Glucosidase Inhibitors. The Alpha-Glucosidase Inhibitors. Now there's going to be a couple prototypical drugs again. Acarbose and miglitol. Okay, so there's our 2 prototypical drugs that we're going to beat. Now, what is an alpha-glucosidase inhibitor? Well, let's go to GI physiology here, and kind of a little bit of biochemistry when you think about it. Polysaccharide. So when you're thinking carbohydrates, a lot of carbohydrates stuck together in a chain is going to form a polysaccharide. Polysaccharides get broken down into disaccharides, and disaccharides get broken down into ooh, I don't know what the spelling was doing there. Spelling's never my strong point. Monosaccharides. So we've got polysaccharides, which is going to be a whole long string of carbohydrate, disaccharides, which are going to be two carbohydrates that are going to be stuck together, and monosaccharides, which are just going to be single carbohydrate molecules. So we're going to take a polysaccharide, break that down in the small intestine, and then what we do is, once we have a whole bunch of kind of disaccharides, we're going to convert those into monosaccharides. And monosaccharides can get absorbed. We really, for the most part, can't absorb polysaccharides and disaccharides. So we need something to break down disaccharides into monosaccharides. This is going to be where our brush border enzymes come in. Our brush border enzymes. Now, our alpha-glucosidase enzymes, our alpha-glucosidase are going to be part of our brush border enzyme system. So within the microvilli there, you're going to have the ability to break down these disaccharides into monosaccharides. Those will eventually become absorbed. However, we're talking about inhibitors. We're inhibiting these brush border enzymes. So we can't break down as many disaccharides into monosaccharides, and if we can't break it down, we just delay it, or we don't break it down at all. So we're either delaying or we're not allowing the breakdown of these disaccharides. So if you have decreased monosaccharides, you have decreased absorption. Saccharides, so your carbohydrates, your carbs get broken down into glucose. When you don't have as many carbs, because you don't have as many monosaccharides, you decrease your glucose. That is the mechanism of action for the glucosidase inhibitors. You're going to inhibit or delay these brush border enzymes, so you're not going to have as many carbs absorbed, which means you're not going to have as much glucose. So let's talk about some adverse effects. The adverse effects. You're going to see GI problems. Now, what kind of GI problems am I talking about? Well, you're going to see flatulence. You're going to see farting. Now, why is that? Well, you have all these disaccharides that can't get broken down. They're going to travel through your small intestine, but they're not going to get broken down by your normal enzymes. Instead, they're going to make its way to the colon, and what's going to happen is all these bacteria, your bacteria love the colon. You're going to have tons of bacteria in your colon. And they're going to see all these disaccharides that they normally don't see because they typically get absorbed by us. But here, we give this drug, we're going to inhibit this. This will make its way to the colon, and all these bacteria love disaccharides. They're going to digest it, they're going to metabolize it, and they're going to form gas. And that's why you get the flatulence. All these disaccharides make its way to the bacteria. They're going to digest this disaccharide into gas, and that's where you get your flatulence. Also, you're going to have these disaccharides act as kind of osmotic agents. The more solutes that you have in the lumen of your GI system, water will follow. So if you have a high disaccharide concentration, water will go into your GI system more so due to osmotic forces. So you're going to have GI nausea, you're going to have diarrhea possibly, just GI problems in general. And that's due to kind of the osmotic nature and the bacterial nature of this drug. A couple more agents to talk about. Again, these really aren't as important. Glp-1 analogs. And then we can also probably throw analogs, amylin analogs. So we've got the GLP-1 analogs and the amylin analogs to talk about. Now, GLP, glucagon-like peptide. glucagon-like peptide. These are going to act by increasing cyclic AMP levels within the cell. What that's going to ultimately do is it's going to increase insulin secretion. We're going to increase insulin secretion. Kind of like what we were talking about before with sulfonylureas, where we're going to increase the insulin secretion, kind of like GLP-1 analogs as well. There are a couple, I'll talk about the prototypical ones before I move on. I forgot we were going to cover that. Glutide. Okay, go back here. Insulin, increase insulin secretion. What you're also going to have is you're going to have decreased glucagon release. Remember that glucagon is going to increase glucose levels within the bloodstream, and when that happens, that's not our goal. So exenatide and liraglutide, it's an E, and here I guess I can make this a little more clear. EXENATIDE. Exenatide. Okay, so these are going to increase insulin secretion. They're going to decrease glucagon release. Some of the adverse effects that you may see. Let's change colors just to keep you on edge. Some of the adverse effects that you can see. Pancreatitis is a big one. Pancreatitis. Also, again, GI disturbances. Hopefully you've kind of learned by now that a lot of these have GI problems. You're going to see those GI disturbances. Now let's talk about the amylin analogs. There's going to be only one prototypical. Pramlintide. So, in a nutshell, amylin analogs are going to mimic amylin. Now, what does amylin do? It ultimately decreases glucose in blood and decreases glucagon. That's it. If I was to remember this, I would only associate the prototypical drug with amylin. We already know that all diabetic drugs aim to do this. All diabetic drugs aim to decrease glucose in bloodstream. That's because in diabetes, you're going to have hyperglycemia. If you have hyperglycemia, your goal is to reduce the glucose in the bloodstream. Also, you're going to want to decrease the glucagon, because what glucagon does is it's going to take the stored glucose and it's going to release it. We don't want to take stored glucose and release it into the bloodstream because we already have too much. So this is the basics of diabetes. Let's go back to the very beginning. We talked about all these different categories of drugs, how they work. These two really aren't as important in the long run. I would remember these 5. Test writers love these 5. So remember, type 1 diabetes, we're going to mainly use insulins. And we talked about we talked about rapid, short. We talked about intermediate and long acting. And then also for type 2 diabetes, in general, our goal is going to be decrease glucose. That's what type 1's goal is as well, except they normally can't make insulin. So we're going to need to supplement it with normal insulin. Type 2 diabetes is, their insulin is typically fine, however, they may need increased concentrations of insulin or other mechanisms because their insulin receptors may not be working as well. Their periphery don't respond to insulin as well. That's the basis. That's as simple as type 2 diabetes can get. So hopefully you found this video useful. If you have any questions, be sure to ask me. I always love hearing your comments. If you found this video useful and you learned something, please click like. It helps build my ego. And then lastly, subscribe for more great videos from me in the future. Thank you for paying attention and giving me your time today.